One of the highlights during my presidency were Stephanie and Dan's Essentials, that I believe is an outstanding contribution. The other one was Corey McBride's work in putting together this module-based curriculum I'm going to talk to you in a second. And certainly, Dana, you blew it off the stadium with your pathway, because I believe what you just showed us is the way we're going to be practicing bariatric surgery for years to come. We're going to adjust this as a backbone for gastric bypass, revisions, and so forth. So the topic I'm going to talk to you today is about transitioning from a volume and time-based bariatric fellowship training program to a by-design module-based curriculum. And I want to disclose my conflicts with education and research grants, but more important than that, I want to acknowledge Corey McBride, as I mentioned before, because she's done an outstanding work in putting this together. You know, ever since Halstead introduced the surgical training based on the German styles residency system with greater responsibility at Johns Hopkins in 1889, nearly 100 years passed and we're still working with the same system in the United States of America, which is basically volume and time exposure, and that's how you become a surgeon. The truth of the matter is that, you know, there's been challenges and surgical training is changing by the minute. The residents are exposed to decreased working hours, a lot of restrictions. They're limited to participate in operations. And there's been an explosion of technology, optoelectronic instrumentation. Surgeries become minimally invasive. We have robots. And because of that, there was an increased demand in training and the rapid development of MIS, and that came with the development of the Fellowship Council. So the Fellowship Council was founded in 1997, so we need to give ourselves a big happy birthday, because it's been 20 years that the Fellowship Council is in existence. And I'm privileged to be chairing and being the president of the council, who is currently responsible to coordinate the matching process of over 215 graduating surgical residents and accrediting over 172 training programs. And I think I want to pause here and say something that's very important. The Fellowship Council accredits programs that will be able to train a resident. The resident or the fellow is certified by the society, not by the council. And we're going to hear then from Dr. Provost, after myself, what ASMBS and ASAQUIP does with the American College of Surgeons in accrediting a center to do bariatric surgery. So being accredited to bariatric surgery doesn't necessarily mean that you're accredited to train a resident or a fellow. This is what the Fellowship Council is made up in 2017. You see all the societies, including STS, SSAT, obviously SAGES, ASERS, HPB, ASMBS, and recently joined by AHS. If you want to see here the number of programs we have, the different diversity of programs, bariatric surgery composes 63, followed by advanced GI-MIS. There are 60 programs. And we have ongoing projects working with different societies in defining what unified standards are, the accreditation overhaul, certificates of focus expertise with the American Board of Surgery, and also recently a pilot advanced GI curriculum with SAGES and SSAT. Now, because of the certificates of focus expertise with the American Board of Surgery, we at ASMBS started to constructing a competency-based bariatric surgery fellowship training curriculum. And this is the publication that you've seen in SWORD. And really what we've been doing is to do a module-based training curriculum. There are two things we need to learn now, which is the term module and milestone that are different. So a base module is progress to the next module when the learner has shown that they completed the curriculum and they completed by achieving those milestones. So that is very important, milestones and modules. And they have cognitive aspects and technical aspects. So these are all the modules that the fellows will have to go through. These are 6 modules: introduction, primary bariatric surgery, short long-term complications, endoscopy, revisional surgery and long-term complications, and last but not least, practice management, MBS-AQUIP, and quality. This is what we are working now. The milestone, each module is made up of milestones. The learner must complete all milestones before they finish the module. There are 2 modules that have multiple choice tests, and there are 4 milestones, 4 modules that have cognitive and technical milestones. Just to give an idea or an example of what is a milestone, how to enter the abdomen safely, how to staple the stomach, how to construct a gastrojejunostomy. If you look at the first module, which is cognitive, and in the interest of time, I'm not going to read you each of those. It's in my handout. They have to go through all these different, different topics. In the technical milestone of this module, number 1, they have to participate in preoperative evaluations, participate in seminars, clinics, conferences. The number 2 module, which is primary operation, they need, from a cognitive point of view, understand what is the conversion criteria, different techniques. From a technical point of view, they need to understand how to staple, how to suture, how to clip. Then we get to the third module, which is short-term complications. You know, they need to understand how to handle a patient that is coming through the emergency room with nausea and vomiting. Is this patient deficient in thiamine, or is this patient having a stricture? And they need to manage that stricture. They need to understand when to endoscope, how to endoscope, when to dilate. And then we get to the endoscopy that by itself has a cognitive and a technical aspect. In the cognitive, when to endoscope and how to do the evaluation before we endoscope a patient. Should we do an upper GI first? And then obviously how to set up your endoscope in the endosuite, how to safely perform therapeutic endoscopy, and so forth. The 5th module that deals with complications in the long term and the need for reoperative surgery, also cognitive and technical. Last but not least, the 6th module, which is practice management and quality. You see the multidisciplinary team, MBSA equipped, that we're going to hear from Dr. Provost. How to perform at least 1 bariatric research project. I think this is also important, and the multidisciplinary patient care. You know, one of the big things that is coming down the pike is these entrustable professional activities. Those are professional units that we can evaluate our trainees, and they can do in an unsupervised setting. So when is this fellow ready to do something without supervision? And we are still learning. We are trying to define what are those EPAs, or entrustable professional activities. This is a new kid on the block, and this is how we're going to be measuring our fellows in training. We're still working on that, on those entrustable professional activities. We believe there have to be 3 created for each module that we are dealing with, for anastomosis, for gastric banding, for short-term complications. At the end of their training, they will have to go through at least 3 EPAs that will cover the patient from the evaluation to post-op clinic visits. And they have to show that they can really take full care of our patient. So we're still working on these EPAs. There is a lot of work ahead of us, high-level tasks. We are revising the curriculum. We're developing evaluation tools for lap sleeve, for anastomotic procedures. And we are also modifying our logging system. Because as I mentioned at the beginning of my talk, it's not anymore about how long you've been doing this and how many you've done, but we want a little bit more information. Is he doing it right? How long does it take? Does he really understand when to do something and when not to do something? The ASMBS has started a pilot project based on this modular curriculum, 10 centers, 19 fellows. We follow a structured competency-based curriculum with cognitive assessment. We have EPAs that have been completed by some fellows. Most have completed the endoscopy and sleeve EPAs. We're using the Simple app, which is an outstanding application that you can see when the fellow finishes a case. You have a small video clip. You have a direct feedback from the program director or from the surgeon that assisted that fellow during that operation. And we are reporting also the operative logs. In summary and conclusion, and in the interest of time, I think that surgical training is not currently, but constantly undergoing change. We are evolving not only from a value-based healthcare system from a volume to a value-based healthcare system, but also from a volume-based training system to a modular milestone and competency-based training system. I think the program directors are still learning how to evaluate these residents and fellows with the milestones, and now we're introducing the EPAs. We are working with the American Board of Surgery in setting up a certificate of focus expertise, and I think we need to do more comprehensive work with different societies. And I think this session, Dan and Dana, has been phenomenal. This is what we need to do to work together with the Council, ASMBS, and the Fellowship Council. Thank you very much.